Okay, this is Dr. Marston, and this week, as part of the psychopathology course, we're going to be talking about bipolar disorder. Uh, so, um, I wanted to start with just sharing something that I checked on and found very interesting, although not surprising, here just a few minutes ago. Um, I have a system that so I have an electronic notes system, and what that means is I can put in my progress notes and put in um, all of my therapy notes. Excuse me, I'm trying to fix something here while I talk. I could put in my therapy notes and other um, uh, intakes, that sort of thing, evaluations into a computerized system. For some of my notes. So anyway, what was particularly interesting is one aspect of this system. What it allows me to do is I can put in a name and it'll show me all the different options for that particular category. If I'm trying to find a diagnosis, it's a way of finding the code that goes uh, with the diagnosis. When you fill out an insurance form, you have to have a code on there. And just out of interest, I put in the word bipolar to see how many variations of bipolar disorder there were. And 49 options came up, basically indicating that there are at least 49 different versions of the bipolar disorder category. Now, that does not include another category. Bipolar um, has also been called manic depressive disorder as a way of reflecting that mania is part of it. And we'll talk about mania. But another category that is another diagnosis that is under the same category that is considered to be a version of bipolar disorder is called cyclomanic disorder, cyclomanic disorder. And that wouldn't have come up when I put in the word bipolar because bipolar is not in the name, even though it is considered um, a form of bipolar disorder. Bottom line of all this is that um, there are at least 50 diagnoses in the DSM that relate to bipolar disorder, some version of bipolar disorder. So that's a lot, of course. So when you talk about bipolar disorder, it is interesting to note how many different variations of bipolar disorder are out there, how many different options you have for that diagnosis when using it um, as a diagnosis. Um, so it's a relatively multifaceted diagnosis. So okay, so I will be spending a good bit of this lecture talking about what bipolar disorder is. And then we can talk about some of the different stress factors and other um, factors impacting on the disorder when we meet this Thursday. So, what is bipolar disorder? Bipolar disorder historically has been also referred to as manic depressive disorder. And what that reflects is that it is essentially um, an unexplained shift in the person's mood. It is a condition that causes unexplained shifts in the person's mood. Now, that 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 definition may seem pretty straightforward, but notice one big part of it: an unexplained shift in a person's mood. So someone with bipolar disorder is not someone who gets angry quickly or gets happy easily or has periods of where things bother them quickly. And so they seem to have quick shifts in their mood. That is not bipolar disorder if the shift in the person's mood can be explained in some way. If someone is having, seems to be doing all right, and then their friend says something that bothers them, and the person seems to become emotionally distressed quite quickly about what their friend said, that is not bipolar disorder. Because bipolar disorder is a shift in mood that can't really be explained for any clear reason. Now, that doesn't mean the person doesn't have something else. For instance, major depressive disorder often carries with it an aspect called agitated depression. In other words, because the person is in a state of depression, they are upset easily. They are made angry easily by things that bother them. So, someone with, say, major depressive disorder may also look like they get angry pretty quickly because that can be an aspect of major depressive disorder. But that's not bipolar disorder. Bipolar disorder is when the shift in mood comes about and it's extreme and it isn't really explainable. Why the person is so upset isn't very clear to someone else being with the person. Uh, so and it tends to last long. Bipolar disorder, the mood changes in bipolar disorder tend to occur and last for a while, as opposed to, getting angry at a friend for something they say, and then maybe they apologize and you feel better. Or it may be on the other end. A friend may say something, get their friend very upset, and then they don't talk to them for years. That's not bipolar disorder. Even if the friend says, hey, I don't understand why you're bothered by what I said and why you haven't talked to me for years. Because symptoms of bipolar disorder don't last for years either. They tend to be in a cycle that lasts a relatively um, brief period of time. Well, not, I'm sorry, I shouldn't say brief period of time, but they don't tend to last for years at a time. Okay. So, um, I'm going to talk about what bipolar disorder is, and then more towards the end, I'll get to some more of the formal DSM diagnosis. But with this particular topic, I like discussing the idea first about what bipolar disorder is, because it's often misunderstood. It's often described as someone whose mood changes quickly, or it's often seen as someone who um, maybe kind of gets really, really um, out of sorts for a while and then goes into a period of time where they just don't know anything. That second one could be what the bipolar disorder is, but it's not really specifically bipolar disorder. People may get easily agitated and easily excited for a variety of different reasons. So let's talk about bipolar disorder. It previously was called manic depressive disorder. It still is called that sometimes. Um, but it is considered to be a neurological condition. Depressive disorder and anxiety are still conditions where it's not absolutely clear if they're primarily neurological or primarily psychological. where sort of the factor is that leads to those disorders. But bipolar disorder is seen first and foremost as a neurological disorder. There's something about the person's brain that they have these quick shifts in mood. Um, and what tends to change in bipolar disorder, because of this neurological condition, is unusual shifts in mood, changes in energy level, changes in activity level, and changes in the person's ability to carry out day to day tasks. Um, and then, for the most part, um, these individuals have mood episodes where they either seem overly joyful or overly excited or extremely sad or hopeless. And of course, as most everyone knows, the overly joyful, overly excited state is called the manic episode, and the extremely sad or hopeless state is called the depressive episode. And then you also could have an episode where the individual is seems to be both. Um, and you can have both. You can have, and that's called a mixed state. And one of the reasons that that's important for later in the discussion is because um, that's actually a large part of the bipolar disorder dis, diagnoses distinctions. And what I mean there is when you give a diagnosis based on DSM of bipolar disorder, you are supposed to state if the person seems manic, if the person seems depressed, or if the person seems in a mixed state. Now, what's kind of interesting, uh, here, let me give you an example of, I think manic episodes are particularly interesting to talk about as far as examples. I mean, we all know people who are in depressed states. If you've worked as a therapist, you know what depression looks like. The person's hopeless, the person can barely get out of bed. That's what they look like. But it's interesting. I have worked with individuals who I thought were in the midst of a manic state. But most of the time, to be honest, when I've seen them in a manic state, it's been when they've come out of a manic state. And there's a couple reasons for that. I'm a therapist, not a psychiatrist. I don't see people um, necessarily immediately. I mean, someone calls me, I'll set an appointment, but even if I'm getting the person in for an appointment, I may not see them till a week later. Well, by that time, the way bipolar disorder usually works, they're probably coming out of their manic state. Um, and so I may not see them for therapy while they're in the manic state. Also, the reality of it is people in manic states don't necessarily see themselves as needing therapy. When someone's in a manic state, they tend to talk um, very rapidly. They tend to be doing things, but because they're in this overly excited, overly joyful state, they don't necessarily see themselves as having a problem while it's going on. It's afterwards that they start to say, "Hey, I'm really having a problem here." And some common examples of why someone who's coming out of a manic state may see themselves as having a problem is some of the things that can be accompanied with manic state is overspending, buying things um, that they don't need. And so, someone's been in a manic state for several days. And then as they start to come out of it, they start to notice what their credit card bill looks like, or they start looking at their bank account and noticing while they're no longer in the manic state that the money they thought was there isn't there. It's not that they lose control of reality. It's just that in the moment, they weren't really paying attention to what was going on. And now that they're coming out of it, they're starting to see the impact of the problem. The other time where I've seen manic states um, really impact someone is um, sexual promiscuity. That very often someone in a manic state will have uh, different sexual behaviors, and they will start to get involved with other people. One night stands are very common. Someone in a manic state. Well, then as a person comes out of it, they start to see what that has done either to them and how they feel about themselves, or more commonly, to their relationship. A lot of people I know in manic state who've noticed there's been a problem afterwards were married, and then they have these sexual episodes and they come out and they realize, oh, and at the moment it didn't really affect them, but as they start to come more to a calmer level, they may start to say, oh, I really made some bad decisions there, um, because maybe they're not married but they're engaged and they're in a serious relationship. Married, not so common, because that's a, that's a whole other uh type of situation. But because again, people in manic states don't lose contact with reality, so they don't forget that they're married. So someone who's married may um, come close to having an affair, but may stop themselves and exhibit the manic behavior in a different way. But someone who is uh, maybe in a serious relationship may find themselves having a number of different affairs uh, and get sexually involved with people. And then as they come out, they realize, oh, this is really going to hurt my relationship. Um, I bring up the things about people being married and maybe finding another way to exert to channel their mania, or someone who is overspending, um, still recognizing that they're overspending, but maybe not being concerned about that. Because I want to really stress this point of view that mania doesn't mean you lose contact with reality. It's not a psychosis. It's not a you think you're someone else or you think reality is different. Um, it's not, you're overspending because um, you think money doesn't actually mean anything, or you're not having affairs because, yes, I'm married, but in my view of reality, marriage means something different. It's not a psychosis, or you believe you're someone different. It's not a psychosis. It's a mood disorder. It used to be thought of as a psychosis, and in fact, you may remember that under that I talked before about how DSM, which is the psychiatric diagnoses, and ICD, which is more the medical diagnoses list, that they match up. But there are a few ICD that aren't in DSM. There is a bipolar disorder with psychosis diagnosis in ICD. There's not in DSM. So bipolar disorder is not considered a psychosis. And there really isn't a version of bipolar disorder that's considered a psychosis. So it's a mood disorder, but that overly joyful, overly excited um, aspect of mania starts to cause problems for people. Okay, I started this part of the discussion by saying that I don't typically see people who are in mania while they're in their manic episode. Um, but I have seen it, not necessarily for treatment. And what's an interesting thing that kind of gives you an impression. I bring this up because it kind of gives you an impression of where mania starts to become an issue. Because sometimes people talk about mania. Well, what's the problem? You're overly joyful. You're overly excited. Isn't Don't we all kind of wish we could be that way? But what's interesting, when I was considering where I've seen people who truly are clearly in a manic state has been when I've done evaluations in the jail. I do evaluations most weeks in the Allegheny County Jail. It's the county jail here, and so I am seeing people. I do it for what's called competency to stand trial, meaning that the judge orders these evaluations if they get concerned that the defendant doesn't even have the mental capacity to participate. They're too far gone psychologically at the time to participate in their own defense. They can't think straight to even help their lawyer or even recognize that they're supposed to help their lawyer. And where I've seen people the most in a manic episode lately has been when I've done those evaluations, because we have these evals are supposed to be done soon after, as soon as possible with the person, because the way competency to stand trial evaluations go is the person can't even move forward towards posting bail until they have this evaluation, because the judge needs to make sure that they're making all the decisions. So basically, if we're not doing them quickly, the person who's competent is staying in jail longer than they need to because they can't get this evaluation done. So we try to do it pretty quick. So I am seeing some people a day, maybe 2 days after they've committed a crime and been taken to jail. Many times, those individuals are clearly in the midst of a manic episode. Like I have their history, and their history indicates they've been diagnosed with bipolar disorder. And I see them, and they're clearly manic. They're talking a mile a minute. Uh, they're sort of um, they're they are being overly uh, animated with their behaviors. Um, they're not talking in a psychotic fashion about how important they are and how important their behaviors are, but they're coming close to it. Uh, Maybe giving some sense that they don't believe anybody really understands what they were trying to do, that only they would have the ability to fully understand what's going on. Um, not psychotic, but clearly coming close to it. Um, and that gives you an idea too of why mania can be so problematic, because people wind up doing things that they might otherwise have had enough wherewithal to recognize that they shouldn't be doing. Um, Now, in that case, it's not the overly joyful that you see the most, it's more the overly excited that you see them, because excited isn't always positive. Anger, agitation can often be described as excited. So you see the excited. Now, where I see the overly joyful as sort of a connection to legal problems and going into jail when the person's um, in a manic phase, is the person gets manic, they get overly joyful, and as part of their joyful, they say, "Hey, let's go have some fun." And what does that? What do some people turn to when they say, "Hey, let's have some fun"? Drugs. So you get a lot of drugs or alcohol. So when the manic would be something that I would describe as more overly excited, it's where the person felt they'd been wronged or felt they needed to take care of a problem, and they just went totally overboard in how they addressed it and ended up threatening someone or thinking they were making. You get a lot of cases where someone says, "No, I really want to make this point," and they're out on the street yelling at people because they really want to get across how angry they are. The police come and tell them to go away, to go home, and they refuse, and they get into an argument with the police. That's more the overly excited episode of the manic stage that leads the person to get in trouble with the law. Where the overly joyful might come in is someone gets overly excited, They say, hey, I've got this money in my account. Let's go spend it. I'll make some more later on, that sort of thing. And in the midst of that, they say, hey, let's go to this store. By the way, on the way there, let's go get some cocaine, or let's go smoke some marijuana, or let's go, you know, drink a fifth of whiskey or whatever. And so the overly joyful leads to the person engaging in substance abuse, maybe somebody who's um, in jail. You hear a lot of people who will say that they got in trouble on a night because they drank and they'd actually been able to stay away from alcohol. Maybe they've been in AA for months, and this is when they broke their sobriety. So you see there kind of where the mania, it's an extreme example in jail. I'm not saying everybody who's in a manic episode ends up in jail or does something illegal. I'm not saying that at all. But it just gives you an example of how extreme the problem can be. And when it does get problematic, why it's considered problematic. Because even if the person doesn't end up in jail, it's kind of where you see it heading. That's why the mania tends to fall into this problematic range, because people, when they get overly excited or even overly joyful, if they're kind of losing contact with, not with reality, but with consequences, um, then it leads them down a bad path. Um, Depression, I'm spending less time on, because depression, we already talked about depression. And most people know what tends to happen. You know, you get depressed, you end up not doing things that you need to do. You end up staying in bed all day, maybe not eating enough, maybe not even, mania could be not sleeping enough. Depression could be sleeping too much. Um, and so on those two ends, you see where it leads. But I wanted to spend that because I wanted to talk a little bit about where mania, why mania becomes a problem. And that's sort of the direction. Even if the person doesn't wind up in legal trouble, which of course I am not suggesting um, is always the case. Uh, but mania almost always sort of winds up in that range of problems, in that direction of that being the sort of thing someone could have trouble with. Okay, so that's mania and depression, and sometimes you can almost see what happens. You know, the person cycles from, they go into a mania, and then maybe they start to come out of it, and then maybe they reach a level, and then they start to become depressed, and maybe even around here it's sort of in a mixed range. Um, and then they start to become, so they may have um, if you picture it this way, if you picture this sort of cycle, you can see a person might start in mania, then come down, and then maybe, let's say this is their normal, quote unquote, normal level of functioning. They have the mania and they start to come down. Around here, you may start to see, around here, you may start to see sort of that mixed, where they're maybe coming out of the mania, but then they're starting to feel um, depressed, and then they maybe start moving into the depressed range. This area here is kind of, it can be a confusing area that changes from individual to individual. Some people with bipolar disorder will describe a period of time where they just feel quote unquote normal, where they just seem to be functioning as everybody else. But then some people, and this is where the more the mix comes in, will say that even when they're not fully manic or fully depressed, they still don't feel right. They still don't feel like they're functioning like everybody else is. And that's where you see more of the mixed episodes. There may be a short period of time where the person isn't clearly manic or depressed and not really having any problems, but a lot of times it may be more of a mixed depression and mania. It can look, that's more of the person who kind of describes themselves as never really feeling right. So they don't go into a normal state and then into depression. They kind of go just from mania to depressed. Like they don't have a quote unquote normal level. And so if that happens, then there's this range where they're going from one to the other and they start to feel more of a mixed um, level. I, I, I guess an example of where you might see a mixed might be somebody who is talking rapidly and seems agitated, but they're talking rapidly and being agitated about how terrible of a person they are. So their statements are very negative about themselves. Uh, or they are talking about themselves in sort of this rapid feature that is characteristic of mania, and they're talking rapidly about how they just can't get the energy to do things that they need to do. So um that can be where the mixed um uh comes in. Uh so um some, like I said, some people with um bipolar disorder have a period of time where they feel balanced, where they feel like everything's okay. Um, but and some people, even people with mixed episodes, may describe themselves as feeling balanced, but the balance is between feeling depressed and feeling manic, as opposed to feeling quote unquote good or normal or whatever. Um, and the other thing about mania that's very important to know, that can be characteristic of depression, but not always, is mania. The person is doing a lot of things that could be problematic for themselves, but they're not recognizing that it's going on. Um, okay. So, uh, symptoms of mania include a long period of time where the person feels overly happy or outgoing, or the person may describe them feeling excited. And by that, they may mean uh, irritable, jumpy, wired. Um, that's how the person describes themselves. And the person with depression, uh, they tend to describe themselves in as feeling empty, as feeling hopeless, and having a loss of interest in activities that they enjoyed. Some of the behavioral aspects of mania include talking very fast, jumping from one idea to another, being easily distracted, increasing goal directed activities. That's why one of the reasons why mania may not seem like a problem to the person, because they may be getting things done that they wanted to get to. You know, people with mania will often describe about how they cleaned their house for the first time in a month. But then when you talk to them, you find out that the reason they cleaned their house so well was because they stayed awake for 2 days straight. Um, Mania could also include being restless, sleeping very little. That's the staying up and getting things done. Having an unrealistic belief in their own abilities, impulsive behaviors, and high risk behaviors. And then some of the behavioral aspects of the depression include feeling slowed down, tired, having problems concentrating, having problems remembering, um, changes in eating or sleeping habits. Again, mania also has episodes of changes in eating and sleeping patterns, but mania may be eating too much and sleeping too little. Depression more often would be eating too little and sleeping too much. It's not always that way, but that's very often how it is. Depression also could include suicidal thoughts. Um, uh, So those are the behavioral and cognitive changes associated with depression and anxiety, depression and mania. People with bipolar disorder um, may describe a period of time where they don't have the symptoms. The symptoms can dissipate for a while. They usually come back if the person isn't getting some sort of treatment. I haven't known anybody with bipolar disorder. Here's how I'll put it. I haven't known anybody with bipolar disorder who haven't been bothered by symptoms if they're not getting treatment. I would say, and I can't say this for certain, um, but I would say clients that I've had in therapy who have bipolar disorder are probably the ones more likely to be individuals that I will see on a periodic basis. My sort of standard view of therapy is if I'm seeing someone for therapy, we will end, but we won't necessarily say that we won't say definitively that the person can't come back. They can, basically it's open door. Someone who's been my client can always come back if they want to. So I end up with some clients who are people I see periodically. And I'd have to say the majority of those clients, the one who's taken me up on being able to come back, maybe more than once for a check-in, um, have been individuals with bipolar disorder. That when you have that individuals with bipolar disorder tend to be individuals who will have periods of time where things seem to be going okay, and then problems will come back. Not always, but more often than other individuals. I'm going to talk about the four basic types of bipolar disorder. Bipolar 1 disorder, and this is sort of easing into the whole DSM, because like I said, there's 50 different diagnoses listed as some form of bipolar. So we're not going to go through each of this, but there are four main types. Bipolar 1 disorder is a disorder that is mainly defined by manic episodes that last at least 7 days. Now, they also have the depressive episode, but it's interesting to keep in mind that with bipolar disorder, bipolar 1 disorder, the main focus is on whether the person has manic episodes. Because if they don't have the manic episodes, then it's depression. But it is defined by having manic or mixed episodes that last at least 7 days or that are so severe that the person needs to go into the hospital. Now, this is usually followed by depressive episodes that last at least 2 weeks. So in bipolar 1 disorder, the depressive episodes tend to last longer than the manic episode. And what's another aspect of bipolar 1 disorder is it has to be that the manic or depression, when they're in the manic or depressed phase, it must be a noticeable change from the person's normal behavior. Now, notice what that means too is it doesn't say that the mixed episode has to be a change. You know, the mixed episode, like I said, can get a little confusing. Sometimes the mixed episode is how the person describes themselves when they're not in full-blown mania or full-blown depression. In other words, they never see themselves as quote unquote normal. That sometimes individuals with bipolar disorder will see the mixed episodes as the closest they ever get to balanced. But the full-blown mania and the full-blown depression must be a clear change from how the person functions most of the time. Okay, so that's bipolar 1. Full-blown manic episode or a mixed episode that seems more manic has to last at least 7 days. And then the depressive episode lasts at least that same amount of time, but could last up to 2 weeks. And again, if you don't have the manic episode, then it's major depression. Bipolar 2 disorder is when you get into a category called hypomania. Hypomania is a manic episode that doesn't last 7 days. so um, there are symptoms of mania, but they don't, um, like I said, they last for less than 7 days. Bipolar 2 disorder is a more rapid change in um, a more rapid change in mood. So the manic episodes and the depressive episodes don't last very long, but the hypomania only refers to um, the manic episode. So the manic symptoms are there, but the episodes do not last for 7 days or more. Hypomania is a more rapidly uh, changing mood disorder defined primarily by shorter manic episodes. Cyclothymic, I think I may have mispronounced that word for it. Cyclothymic disorder uh, is a milder um, form of um, mania. Um, uh, so it's when you have someone who seems to rapidly cycle between manic and depressive, um, but the symptoms are less severe. Hypomanic episodes are manic episodes. They clearly are manic, they just don't last as long. But sometimes you'll have an individual who seems to rapidly cycle between depression and anxiety, um, but they never seem to be like they just never seem to be as severe manic and severe. There's less severity or less symptoms of the mania. So it's a milder form of mania. So hypomanic is manic, but they last a shorter time. Cyclothymic is milder form that also lasts a shorter time. And then the fourth category is just not otherwise specified. And actually, that would be bipolar disorder unspecified and bipolar disorder otherwise specified. And that's just sort of a catch all category for someone who has um, uh, symptoms of bipolar. It just really, it's not, you're not supposed to use it that much, as I talked about before with DSM. You're always supposed to try to do as much as you can to not use these otherwise specified uh, categories. Okay. To finish up here, and we certainly can talk about a lot more about the etiology of bipolar disorder and the treatment aspects. I think, as we talked about before, I'd said that dialectical behavior therapy was developed as a way, primarily, of treating bipolar disorder. It's used for other ones, but its primary um, treatment focus initially was bipolar disorder. But I wanted to talk about um, the DSM-5 criteria to some extent. One of the things that's interesting at the beginning and to talk about is this whole idea of how I said that bipolar disorder is not a psychotic disorder. And it's interesting that when you look at the DSM-5 um, category, when the criteria in DSM-5, there is a section, as there is with every diagnosis, it says that one of the things you need in order to use this diagnosis is you have to be able to determine that it is not better explained by some other diagnosis. And it's interesting to keep in mind that in the DSM 5, that section, all the alternative diagnosis, this is called the differential diagnosis section, where you consider, is there another diagnosis that could explain this better? All the all the diagnoses listed as alternatives in that section when it comes to bipolar disorder are all psychotic disorders. So they are all disorders that um, would be ones to consider, and the reason they're listed as ones to consider is they would have psychotic features. It's a real clear indication that um, when it comes to bipolar disorder, um, sort of the other section that's strongly considered for most people who have psychotic disorder, who have bipolar disorder, are the psychotic disorders. And the distinction is that um, bipolar disorder doesn't have delusions, hallucinations, that sort of thing. So some of the diagnoses listed in the differential diagnosis section are ones that we'll discuss when we get to schizophrenia, and those are schizoaffective disorder, schizophrenia, schizophreniform disorder, and delusional disorder. Um, I will say that schizoaffective disorder is probably that's a diagnosis that probably is most closely associated with bipolar disorder, but it has the psychotic, the delusions and hallucinations. So schizoaffective disorder is in many ways many of the same symptoms of bipolar disorder, but also having the psychotic features. Schizoaffective disorder also does not have, it has symptoms of mania and depression often associated with it, but they don't have to be as clear cut as they do with bipolar. With bipolar, it has to be clear episodes of mania and clear episodes of depression in order to have that diagnosis. Okay, um, just some things to keep out. What are the diagnostic criteria for a manic episode? Um, Lasts at least 1 week. Remember, I said that before, 7 days. And some of the symptoms that have to be present. There's a list of, I think it's eight, and you have to have at least three of these during that period of 7 days. And some of those symptoms include decreased need for sleep, increased grandiosity or self esteem, easily distracted, racing thoughts, that sort of thing. And as always is the case, the mood problem has to impact the person's social or occupational functioning or require hospitalization. And then the symptoms for the major depressive or for the depressive phase of the bipolar disorder. Um, uh, Again, these episodes for a full blown bipolar 1 disorder, the manic episodes have to go at least 7 days. The depressive episodes have to go at least 2 weeks. So the depressive episodes in full blown bipolar 1 disorder last twice as long typically as the manic episodes. And some of the symptoms of the depressive episodes include depressed mood, decrease in interest or pleasure, sleeping too much, being very tired, decreased ability to think or concentrate. Um, Now, it's interesting now to take a look at um, uh, what is defined as hypomanic uh, episodes. Um, and hypomanic episodes, again, are consistent with bipolar 2. That's so you've got these depressive episodes with bipolar 2, but with bipolar 2 disorder, you have hypomania instead of full blown mania. And here's the definition in for um, hypomania, you have the same symptoms of what makes a mania, but um, they only have to last at least 4 consecutive days and have to be present most of the day, nearly every day. So on those 4 days, it doesn't have to be that they're there for the whole day. It's just they last most of the day, um, almost every day of those 4 days. So 4 days, and it has to be present most of the day, almost all 4 of those days. So there could even be 1 or 2 days where they're not present the majority of the day. Um, so, um, where they're, or at least where they're present less often than they are the other days. So 4 days as opposed to 7 days, and they don't even have to be present the whole day. So that's the hypomania uh, section of what makes up bipolar 2. And it's interesting now to consider cyclothymic disorder. Um, in many ways, cyclothymic disorder is almost like that persistent depressive disorder diagnosis I talked about when we talked about depression, which is where there never seems to be a period of time where the person is not depressed, but they also rarely ever seem to have a full blown major depressive episode. They just seem to be functioning at a sort of depressed level. So here's some of the diagnostic criteria for um, cyclothymic disorder. It is when the person had, it has to be present for 2 years, um, where the person has hypomanic symptoms but do not meet all the criteria for hypomania, and have depressive symptoms but do not meet all the criteria for major depressive disorder. And during that 2 year period, the hypomanic and depressive periods have been present at least half the time, and the person has not been without the symptoms of either for more than 2 months at a time. So it's gone uh, 2 years, present at least half the time, either the hypomania or the depressive symptoms, and there's been no more than 2 months where the person has seemed to be without them. So notice how compared to like the full blown bipolar 1 disorder, this is sort of like they're just sort of maybe not always there, but are there almost all the time. Uh, and the person has never met all the criteria for a hypomanic episode or a major depressive episode. So the symptoms of either depression or hypomania have been there, but never in their full blown form. So cyclomania, hypomania is sort of more rapidly changing mood disorder, and cyclomania is almost, even though the symptoms are more the hypomanic one, it's almost the opposite. Hypo bipolar 2 is rapidly changing. Cyclothymic is just sort of always there in some form or another, the hypomania or the depression. So the person either has hypomania all the time or sort of this mix of hypomania and depression all the time, or um, a mix that's sort of more depressed. So there's symptoms of either hypomania or depression present most of the time, but never a full blown episode of either. Okay. Uh, I've got that we're about an hour, so this would be a good place to start. Keep in mind, bipolar disorder, as I said before, is a very, it's a complex mix of things. One thing I didn't talk much about before is one of the reasons why it got used a lot um, with children and adolescents still is because it's the only diagnosis that mentions anger and agitation as a criteria. And of course, teenagers in particular often have problems with agitation. Um, uh, and as I said before, there is a form of depression called agitation, but it's not listed as a primary criteria. It's listed as a form of depression. But bipolar disorder specifically mentions excitability, um, and agitation, frustration. So so uh, because of its stronger emphasis on anger as being a symptom, as opposed to many other diagnoses, um, uh, bipolar disorder ended up getting a lot of attention for uh, teenagers. So Um, that's why, that's one of the reasons why it was used so much with teenagers. That's been sort of discouraged lately. Um, by talking more about agitated depression, talking more about disruptive mood dysregulation disorder, which is an anger management diagnosis in DSM 5. But for a while, bipolar disorder was one. One of the criticisms of it, let me just finish with this. One of the criticisms of using bipolar disorder for teenagers is it wasn't bipolar disorder was the only diagnosis mentioning anger and agitation. It was the only one that had a medication specifically for addressing the problem. And the criticism was that bipolar disorder was used so much with adolescents because it was an excuse for getting them on medications. The other ones, where anger and agitation can be an identified problem as a criterion, disruptive mood dysregulation disorder, oppositional defiant disorder, um, are not ones that have a medication associated with it. So that's why it was criticized, um, talking about bipolar disorder so much with adolescents. Okay, I will see you on Thursday. Have a good week.